I'd like to present the following poster: Use of the E.P.I.S model to target parental burnout in pediatric practice. And this represents our team, such as myself, Dr. Denise Gobert, Dr. Rebecca Martel, Dr. Jessica Silvera, and Taylor Glasgow. Our team is also representing a collaboration between the Texas State University DPT program faculty and also the therapists at Cole Health Pediatric Therapy. So our research effort is primarily due to a growing problem that we have among caregivers of those pediatric patients that might have disabilities. And so this project utilized the E.P.I.S implementation science framework, which consists of 4 phases aimed at systematically improving clinical practices related to parental burnout. The goal of this project was to determine how to best assess and monitor parental burnout in association with patient-centered care in a pediatric multidiscipline outpatient clinic setting. So what we used was a practice-based research design that is called the E.P.I.S framework. And the framework includes 4 phases. The first phase is exploration, second is preparation, third is implementation, and the fourth is sustainability. The project was conducted among the therapists at the Cole Health Pediatric Therapy clinics in Austin, Texas. And it included the speech therapists, occupational therapists, and physical therapists in the outpatient clinic setting. So if you look at the diagram here, you'll see that the study actually took place over all of these phases over 9 months, from the exploration phase, preparation phase, and now we're in the implementation phase. We started this project back in the fall of 2024, and the phase was conducting monthly meetings among therapists to identify how could you actually have an outcome to measure parental stress or any risk for burnout. And so basically, what we did in phase 1, which is that exploration phase, is we had multiple team discussions, monthly meetings, and also a literature review to find an assessment. We decided on the caregiver stress and caregiver benefit scale, or the CSCB-10, that was developed by the University of Washington. And so we got approval to use this assessment tool for our research project. So then the preparation of integrating this tool into the system. And the goal was to make it a part of clinician workflows that was using the electronic medical record system. And this would assumingly have a seamless adoption of it as a routine practice. So what came next were onboarding luncheons in this preparation phase, where the staff were allowed to have discussions, Q&A sessions, and so forth to inform everyone of the value of having such a tool. It was finally implemented in phase 3. The implementation phase was where it was adopted into the secure IT system that was a part of the electronic medical record system. And so then it was a matter of how to train therapists to utilize the tool as part of the intake packet, as part of the initial eval. So right now we're into the implementation phase that started in March of this year, 2025. And so the tool is now being used system-wide. And so patients, the parents fill out this form as part of the initial eval packet, and therefore we are now in the process of using it. What we'd like to do is report on some of the preliminary findings. So it's been implemented starting in June 2025. That's this summer. And from the summer, June until August of this year, we have 74 completed surveys that we'd like to kind of report on. Well, the average for the survey scores was 17.76. That's a raw score. And according to the calculations, what you calculate is a T-score that normalizes the score to the general population. So the normalized score or T-score was 45.6. And that is within one standard deviation of the average of community adults who do not have any pediatric care or are not in the role of caregiving. But what we did find is that there were three key identity type of traits that should have some attention. And so what we did was we looked at all of the items, which are 8 that are part of the tool, to identify 3 of the factors that were majorly contributing to the total score. And those I identified 3 main factors were number 1, always feeling like you're on call. Number 2, time with friends. And then number 3, feelings of being overwhelmed. And as you can see here, those are the ones that are identified as the major contributors to the scores that we had for the parents. So what did this mean? This meant that the primary first factor was that the parents were feeling like they were always on call, like they're always on a fight or flight type of mode, being ready to act. The second most frequent contributor to the score was that there was feelings of difficulty in socializing with friends or feeling isolated, since that they could not really freely associate with friends and so forth. And then the last one was a third factor of feelings of being overwhelmed. And so in our discussions, we feel that this actually contributes to a sense of feeling like a lack of capacity to address the child's needs. So as part of our implementation phase, what we're doing now is that we're going to try to incorporate parents within the treatment sessions as part of the hands-on type of activities. Also with lots of encouragement to the parents as part of the treatment of patients. The other thing is that using the goals for long-term and short-term goals, we would like to include the parents in some of those goals and how they might interact in those goals. So goal setting is something that we're in the process of doing now. And then one way to help with this is that we're going to have regular in-service presentations and helpful tips and handouts to help therapists as far as setting these goals to implement use of the information of these tools in their practice. So we're in the implementation phase, and we thank you for listening to our poster, and hopefully we can answer any questions that you may have about our research. Thank you.